because that one's better in color. You think that's why?
No,
we should go
well,
with
this one, I got this one working there, so that's. But he's got it all set up for this, right? You have it hooked up.
Is it easy for me to do it on this one so we can get better color?
I would, if you give me like 5 minutes, I can see if I can get audio or video out of that one over there.
I would just.
We'll just stay here then.
Just do this.
Yeah, we'll just stay here. So let me remove this microwave.
Yeah. So what we're going to do is we're going to open up. We can actually. I don't know if you're going to be able to raise a flap. You may be able to just open up the. Just cut the eardrum.
We might have to do that.
I don't know if you can.
Let's see.
You could try to raise a flap if you want. So with the hyperacusis, what we need is a good exposure of the middle ear and the ossicles. So you may have to do a little drilling like you do for stapes.
Yep.
And we put, essentially we put 10 little pieces of 2mm fascia around the stapes and on the incus and on the foot plate. And the ones you want to jam in there are from the promontory to the foot plate and the facial nerve to the foot plate.
Okay.
And so you want to get those pieces in there. So the obvious, what you want to do is to try to stop the stapes from moving so much.
So we're going to make a 12 and a 6 o'clock incision here, see if we can get a tympanomeatal flap raised.
All right. And then we put 2mm pieces on the round window and 1 4mm piece over the 2mm on the promontory.
Okay.
And we scratch the promontory and the round window niche so it'll stick, so the graft will have some blood supply. And then, so that's for the usual case. And then for the more serious cases, we're adding an extra piece of 4mm temporalis fascia over the incus, over everything that you put in.
Okay.
So that's another piece, and then put another piece of fascia in like you're doing a tympanoplasty.
Okay.
So you'll have 2 layers of your drum in the back.
Right.
And you have like this tent over the stapes and incus with all the other temporalis fascia below. And that's it. And that's you close it, and that's the procedure. So the extra tissue, we're just doing the new study on it. So I don't know about I know that if you use the 10 and the 2, and the way I said it, I know that'll work pretty well. If especially if it's very important to do the LDLs before you do the surgery.
Okay.
Because you can tell the patient, give them,
some
probability.
Some of those patients with hyperacusis.
They're crazy.
They're
They're all little.
Desperate for.
Yeah, they're very emotional, and it ruins their life. Oh, great job.
You maybe be a little more delicate with this, but I want to reflect it back.
Oh,
so
this
you
is
can
great.
see the anatomy.
You're doing good.
So you can see the long process of the incus and the stapes here first. Obviously, in a human, a live human with live tissues, this would, kind of fold back on itself and just kind of stay out of our way.
If it gets in the way, I would just pull it out, just cut it out, and just tear it out, so they can get a good view.
Patients all have good hearing, and so you want to be very delicate around the ossicles here, which is a little difficult.
So the first couple of years, I was afraid to touch the stapes, so I just put 1 little tiny piece on the foot plate, and did mostly round window. And those results weren't as good until we started packing around the stapes.
Okay.
But I was a little nervous about touching too much of the, getting a sensorineural hearing loss. So we've sort of gone little steps, step by step.
Sometimes you need to drill the sputum a little bit, or tear at the sputum a little bit, just to get a better visualization of the
Right.
of the ossicles and the oval window.
Now, are you stratifying yours into two depending how severe it is, or
Yeah, yeah.
because you're not doing the same thing for everybody?
Well, we've done everything the same for everybody up till now. And then just a couple weeks ago or a couple months ago, we just started with the new adding more tissue on the very severe cases.
Okay.
And I think the results are going to be much better.
Okay.
So I think if you know, as long as you talk to the patient and we tell them that they may get they may get some hearing loss from putting the extra tissue in. We're not sure. And the first couple of them had a little conductive loss right after surgery, which may go away. And actually having the conductive loss may be helpful because most of them have perfect hearing. So you're really not hurting them by giving them a little loss. And but I would let us do we know that the other, if you pick a patient from 70 to 90, and you can give them 80% chance they're going to be better. So I'd pick those patients. And then if you have somebody below, you can tell them it's a 50-50 deal, and so that's what the numbers are.
So we're looking at the long process here, obviously, of the stapes under it. Looks like there's some kind of adhesions down here.
Wait, point out the ossicle. Like, go up under. Can you go under higher power?
Yes, sir.
And there's a little piece of skin blocking the.
I see that.
It's actually more lateral than that. Yep. Yeah, you got that out of there. Good. You going to put the speculum in there?
Get this one piece of the TM that's hanging down.
Yeah, I'll just pull that out with that cup forceps. Yeah, just get rid of that. Good. You have a bigger speculum than that, or is that about the
This
biggest?
might be the biggest one we have here.
Okay.
This is a 5.
Okay, stay in this. Try to stay in the center. There you go.
We can magnify
Oh
more.
yeah, that's much better. Now point out the incus and stapes. Okay.
So, wish I had an angled instrument to the straight one. Is there an angled straight tape over there?
Let's let the signal know.
Yes. So I can keep my hand out of the screen. Thank you. So we have the long process here.
Right.
IS joint right there. You can see if I move the long process, you get a visualization of where the IS joint is. It's right here at the tip of the.
Could you do me a favor and just turn the bone a little bit to make that more superior? Just rotate so you put the incus in the right surgical position. Just turn the whole thing.
It's kind of tricky.
It still looks like it's coming from the bottom. Is it hard to turn the?
The speculum holder won't really allow me to get it. in
You
the
can't
exact
just turn the
orientation that we
whole
want.
dish. Just turn the whole thing.
So this is a right ear?
This is a left
Left ear.
Oh, okay.
So this is the
Okay.
12 o'clock position if you're at the
Okay,
instrument. This is
okay.
the handle of the malleus here.
Okay.
Right.
This is the long process of
Okay.
incus here.
All right, that'll be okay.
Clear out this adhesion there.
Oh,
See a
good.
little bit
Yeah,
better.
that's much better. Yeah.
Okay.
This is more of a surgical view here. I'm trying to hold the bone in position with my hand to keep it that way. So we can see the long process. Obviously, the head of the stapes under it. You can imagine the oval window being down there. In this area, anterior to inferior, posterior to the oval window is where we want to start putting these grafts. So
Right.
harvest a big piece of deep temporalis fascia through the smallest incision possible, kind of going along with the minimally invasive sort of concept. Here we're using a Cook otologic graft that we cut up because we didn't have fascia. So you cut 2 millimeter pieces using a 2
Right.
millimeter punch,
Right.
and
So-
you cut 12 of those. So we're going to take our first 2 millimeter piece. Get back on the screen here. Moved.
So you should have a good view of the foot plate and the facial nerve and everything,
Mm-hmm.
just like you were doing
For
a stapes.
stapes, yeah.
And you want to scratch the promontory a little bit
Yes, sir. Yes.
and scratch the round window.
Mhm.
Just
Scratch the promontory here.
yeah. And
Get
then
some bleeding going.
you try to get some at the round window underneath at the bottom of the niche.
Mm-hmm.
Okay, good.
So we're ready to start putting the grafts in.
Right.
Take a 2 millimeter piece.
Hold it near.
And our first one's we're gonna focus on the oval window, or the round window first.
Yeah. So you try to put these in dry, because what happens as soon as they get moist, they start swelling.
Mm-hmm.
So you put them in dry, and then as you work, you'll see that it'll just start swelling as you keep going on the procedure. It's stuck to the instrument.
No, it's stuck to the part of the.
Are they
tube.
wet?
They're not, no sir.
They are wet or not?
Not wet, no.
You may have to wet it.
Mhm.
A little squirt.
Yeah, you can wet those grafts a little bit for us. So this first one goes on the round window. Usually we don't do this under such a high magnification, so it's a little bit hard to work with under such a high magnification. So that one goes right there on the round window.
All right, you got to move the scope is a little off. You're off to there you go. Try to stay in the center. That's perfect.
Mm-hmm. Take another one. So we're gonna do another one to the round
Oh,
window.
You know what, I wet the wrong stick. I wet that as Joe format.
Yes. So we got 2 millimeter pieces on the round window, times 2 now.
Then we put a 4 millimeter over that onto the promontory to hold it in place. That was the,
That's in the way.
That's the first procedure that we did mostly for about a year, 2 years.
Then we'll take a 4mm piece.
Yeah.
Is that the gel foam or the fascia?
Looks like gel foam.
That's the gel foam there. Yeah. Thank you.
So take a 4mm piece.
You put the 4mm piece right over the 2mm round window and onto the promontory.
You kind of drape it over the promontory and let it fall over the round window.
Yeah.
Gently kind of push it in snugly to the niche there.
Good.
TM out
Oh,
there
that's
for
nice. Oh, that's very good.
So now we can start focusing on the oval window.
Right.
We'll get a 2mm piece.
And now you just basically start putting it around the stapes circumferentially.
All around it, yeah. Just try to cover the whole area there with fascia.
Just get whatever gives it to you first, you can put it. So we're going to go inferior to here first.
And you want to get it underneath the stapedius tendon if you can, and next to the facial nerve and next to the promontory. Sort of jam it into the inferior foot plate where the promontory comes in. You just stick that in there like that.
So you're trying to get it under the crurer also? That's a little tricky.
You don't have to necessarily get it in between the
Okay.
anterior and posterior crews.
Wait, stop. Yes.
Okay,
You do. No, you do put it in. You get it all around. Actually, sometimes there's adhesions there that would stop you from doing that, but most of the time you can just push it in there.
So we're going under the stapedius here with this one. Are we still on the screen now?
Yeah, doing good.
Anterior with this one.
I do like using the idea of
Can you see
using
the
biopsy
angled one I
punch.
was using?
Yeah.
Oh, I
Yeah,
can
that
figure
makes it real
Makes it
easy.
nice,
Yeah,
yeah.
it makes it real easy to make the fascia
Mhm.
pieces. And
the anterior with that one.
we used to try to cut them, you know.
Yeah.
We'd like to get one superiorly.
So I think that's probably enough demonstration to get the people trying it,
Absolutely.
because it's just a matter of, keep packing them in there.
Absolutely. Yep. It's going to rinse and repeat this step for a while,
Yeah.
basically. And then we put the 4mm one over the top of the.
Not right now.
Not yet. We
No,
would do
no.
more 2mm ones.
Yeah.
But eventually, after we complete the circumferential.
No, I don't think so. I think just do the 10 pieces and the 12 pieces, because we don't know the results of the new surgery, the new procedure.
So we're just. So
we
just one
should
of
we
the,
should yeah we should be the ones to do it.
Mhm.
If we're going to get into trouble or get too much hearing loss or whatnot from
Absolutely.
doing it. But we know this works, so this is a good way to do it.
Well, I like that it's reversible.
Yeah.
It's minimally invasive.
Yeah, we've never
could-
had a patient ask to
Never
take
had
it
that,
out.
yeah.
No.
That's good.
So
So
Ooh.
everyone, do some.
what?
If you'd like to.
Yeah, who wants to try next? Why don't you suck out the graphs, and then so they can, you want gloves?
That's okay.
If you have suction,
Oh, I'm
you
good.
can,
Yeah, you guys.
The fellow lives in the temporal bone knob. I'm one with these bones, sir.
That is true.
My section's a little weak, unfortunately. It's a problem.
I don't know why that is.
I still got pictures from when we would do dissections in the lab here. I took some pictures for you when we did that one superior canal, the transmastoid. You
Right.
had me fenestrate the canal, and we did the transcochlear approach, and
Really cool.
yeah. So the cochlear-vestibular nerve section.
Yeah, we did about
We did-
100 of those.
Yeah.
And then cochlear implant came in and
Right.
said, you're not going to
You
be
can't
able
do
to
that
discomport
anymore.
it.
Yeah.
Well, I said
Yeah.
it's, even though it did help tinnitus in about
did,
70,
yeah.
80%,
Yeah.
because in Meniere's disease, the tinnitus, I think, is peripheral
Oh, yeah.
in the inner ear.
Yeah, I liked your comment yesterday when you were talking about the dexamethasone and Meniere's. And yeah, I do think, if you think about the etiology,
It,
in that case, it's probably peripheral.
and it's also, it may be all allergic too,
Yeah.
because, we talk about autoimmune,
Right.
the bilateral,
Right.
and treat them with steroids.
Right.
Um, the
It's gonna be easiest
the
for you.
fact that they respond to oral steroids, high doses,
So I'll start
and
by
that the
handing you the 2
unilaterals
millimeter.
respond, it may be all be allergic, all may be something to do with a hypersensitivity,
Right.
then
Kind of immune-mediated phenomenon.
yeah, the whole thing. Of course, Kuhn believes it's all migraine.
Migraine, yeah. Truth is probably somewhere in between. There's probably
Yeah,
a combination.
right. Actually, you could just keep putting more tissue, more in there, and you don't have to take them out.
So that's a 2 millimeter graft.
That's a good technique. Looks like you spent a good amount of time in the lab during residency.
Yeah.
You said you're 4 right now?
So it's 2 millimeter. You can see that area in between the stapes and the promontory. Gives you like that little wedge or crevice there. You want to try and stuff it down in there, but gently, obviously, because we don't want to disrupt the foot plate or anything. But we do want to pack it in there snugly to get some dampening effect. Yeah, because that TM is kind of in the way, it sticks a little bit more. That would be a little bit less of a problem in a live patient, because that TM flap would be sticking to
Out
the
of the
anterior
way,
canal
yeah,
a little bit
yeah,
better.
be out of the way, yeah.
Good.
Yeah, just push it right down. Good. That's good. Yeah.
Let's do a couple more.
Are you getting to put some of the pieces in, Johnny?
I think I need to take this scoot down a little bit here.
Oh,
Yep, I got a curette for you.
Okay.
It's a little bit wide for what you'd want to
Oh, that's not gonna work in there.
use, but it worked over here.
It did?
Mm-hmm.
That's a mastoid curette.
Yes, it is. Great. Yeah, that's great.
Work around your hand a little bit better.
I'll try and get one under the stapedius. That's great. Yeah, push that down a little bit deeper. Absolutely. That's awesome. So you got some nice 2mm pieces that are surrounding
We're
your
doing a
foot plate.
hypercusis now.
Are you almost done?
We
Yes,
can
sir,
be
we are.
we can be done whenever you want.
Yeah.
When should we be done? What time?
12? In like 10 minutes, 5 minutes?
Well, Johnny is just getting ready to put some. You're just.
It's okay though,
You're okay.
yeah, I'm okay.
Okay. All right, we'll go to 12 then.
So take this 4mm
Jack,
and put
at
it
12 we just go
on
home.
the promontory
Or
and
you
let
doing
it drape
anything at
over
12?
the round
You
window.
doing anything at 12 or we just go home?
Well, there's lunch there.
Oh, there is.
And then when they're done there and here, then we're going to take them to show them how to do MIPS and OSCE and stuff like that.
Okay. All right.
Yeah, so put that one on the promontory and let it drape over the round window. He's doing the 4mm graft over the round window now.
A 4mm graft over the
Over the round window.
Oh, okay, yeah. See, I think it's better to have, the thing that makes me nervous is that, people will start doing this around the country and all do it different.
Yes.
Everybody will do it different and they're going to say it don't work.
Yep, so we got to really
It's-
standardize
So
it
that's why I
early on.
think it's got to be standard.
Basic,
that-
minimal,
yeah,
standard, and we
and
go up
yeah,
little by little on
yeah, and then,
using more
right.
tissue once we're confident about it.
and then if the patients,
Mhm.
we'll try to bring them in here, so we
Absolutely.
can, so make sure we get the, best result that they're gonna get.
Yes, sir.
Because, something like this, if a couple guys, like the round window, occlusion,
Mhm.
the results
That's
weren't,
great.
yeah,
Yeah, that looks good.
they were
Well
not,
done, man.
they were not as good as, the middle fossa and the transmastoid.
Mhm.
So they poo-pooed it right away. They said, this is a lousy operation Herb developed, putting blocking the round window.
Yep.
So it's, you've got to, keep doing it,
Yes, sir.
And,
Then we looked at the results of it, and our results are very similar to the results of the mid fossa and
Really?
transmastoid
Yeah.
approaches for the superior canal repairs and such. So in the mid fossa papers and stuff, they get 50-60% in improvement. A lot of them don't improve hearing; they improve the other symptoms.
is that right?
Yeah,
I thought
and
I thought they improved the hearing.
Not significantly in some of the studies. Not significantly in
Oh,
some of the
very
studies.
interesting. All right, you can turn it off. Great.
So that shouldn't be the primary